All right, everyone, welcome. And today we're going to be covering the Lever chapter on cutaneous lymphomas and leukemias. And there's a lot to cover in this chapter, including some unusual and maybe less common entities that you won't see very much in clinical practice. So we're going to try to keep this to the most common entities and what's really relevant for boards and clinical practice and things that you're going to see in kind of a more simplified approach. And we can definitely get more in-depth with a review or questions if you have other questions or things that you'd like to cover. So basically lymphomas, to be very simple, can be divided into B and T cell lymphomas, and these can involve the skin either primarily with no extracutaneous involvement at the time of diagnosis, or you can see secondary involvement of the skin in the case of an underlying systemic lymphoma. And then there are also cases that can resemble lymphoma that we can see, say, in the setting of an insect bite reaction or drug reactions, or even scabetic infestation that can mimic lymphoma but are not actually lymphoma. And these classifications can change over time. So things that used to be lymphoma are now not lymphoma, and things that we thought maybe were benign, we now realize might be more aggressive. And these classifications, which are governed by the World Health Organization, change over time and they can evolve. So names can change, provisional entities can be added or removed, and nomenclature can change over time. So it's important to stay updated and have the most current names for things and know that things might change. So what has one name now during training might be known as something else in 5 or 10 years from now. So we'll try to make sure that we keep you updated, and as things change, we'll amend this lecture. But just know, if you're listening to this 5 years from now and the name is different, we didn't do that, but things change. So as of 2021, this is the most up-to-date nomenclature. But if you listen to this in 2026, this might be out of date. So most important things to know, and things that you're going to see very commonly, would be in the realm of T cell disorders would be Mycosis Fungoides and CD30 positive lymphoproliferative disorder, which encompasses a few different things. And then subcutaneous peniculitic T cell lymphoma. And then for B cell lymphomas, you really want to be able to separate out the low grade lymphomas, which have kind of a nice, happy behavior. And as some of the experts on these things will say, you can spit on them and they go away and like kind of just live happily with you, and they don't really have a bad prognosis, like marginal zone lymphoma or follicular lymphoma, versus some of the bad actors like gamma delta lymphoma. Or actually, sorry, that's a T cell lymphoma, but large cell lymphoma, leg type, which ironically doesn't have to be on the leg, it can be in other areas of the body. So important to know some of those lymphomas that have bad or maybe not so bad prognosis. And to initially work up a lymphoma, we often start with CD markers if they're maybe not so well differentiated. So the example that I'm showing here has some germinal center phenotype, where you can see that it's kind of recapitulating what we would see in a normal lymph node architecture, where we have these pale areas centrally with a surrounding rim of smaller lymphocytes. And this is what we would typically see in a normal lymph node. So if you go way back to histology in medical school, you might remember that at the center of the lymph node, we have the germinal center, which typically has these larger cells, and you can see these little bodies within the macrophages. These are called tingible body macrophages. So when you hear that nomenclature, it's these little pieces of material that have been digested by the macrophage, and then you see the remnants of those are the tingible bodies. And that's a normal structure in kind of a benign lymphoid follicle. And then at the periphery, we have the marginal zone, which has smaller lymphocytes. And then around that, we have the mantle zone. And that's what we would see in kind of a normal lymphoid follicle. You can see that we have these bigger cells at the center, which are composed of centrocytes and centroblasts or immunoblasts. And the centrocytes have cleaved nuclei, which have kind of a coffee bean architecture. And then the centroblasts have more open chromatin and kind of a stippled configuration. And then at the periphery, we have these smaller lymphocytes that are more monotonous in appearance. And those are the marginal zone and the mantle zone. And then usually in this area, you can also see some eosinophils and some plasma cells and kind of an admixture of cells. And this is what we would typically see in a follicle center lymphoma. So this might not be one where we need a lot of immunostains, but if you see more of a nodular proliferation of lymphocytes, that might be where we would start with some basic markers. And important to know that T cell markers are CD2, 3, 4, 5, 7, 8, 30, and 56. And our common B cell markers are going to be CD5, CD20, CD79A, CD10 and CD21 are going to mark the follicle center here. And then BCL2 and BCL6 also for the center of the follicles. So let's say if we weren't sure and we had an area, maybe this wasn't bisected and we had an area that looked more like this and we saw kind of like a dense lymphocytic infiltrate and we were wondering maybe about a leukemia or a lymphoma, and we have many of these lymphocytes kind of in an interstitial pattern here, or almost in an Indian filing pattern where you might wonder about breast cancer. This type of pattern might look more like a leukemia cutis. And we have this very monotonous pattern of lymphocytes kind of Indian filing through the collagen bundles. Here we have a random kind of larger lymphocyte. In this area in particular, you might not be sure whether these are B cells or T cells. So just looking in this particular focus, this might be an area where we would get markers and get a CD3 and a CD20 to see, are these B cells and are these more T cells? So if we see more CD20, then we'd be thinking more of a B cell lymphoma and get more B cell markers. And if this were more CD3 positive, then we would be thinking more of a T cell lymphoma and get additional T cell markers. And often if we're concerned about a lymphoma, we're going to be getting quite a few unstained so that we can continue to work up that lymphoma without needing to take a lot of extra time to work this up. And then often clinical history is really helpful. So we'd want to get some additional clinical history to see that, does this patient have a history of leukemia or lymphoma? And the site is often helpful. So if we know the site on the body, where the lymphoma is, the age of the patient, clinical pathologic correlation is very helpful with lymphoma. So knowing where on the body the lymphoma is and additional clinical information is very helpful. All right, so in this case, what we're seeing is a follicular lymphoma. So the cells here resemble the follicle center cells in a normal lymph node. And these are most commonly seen in the scalp. And you can see either a follicular pattern, a nodular pattern, or a diffuse pattern. And typically these are going to label like a B cell lymphoma. So all these areas here with these nodular clusters of cells are going to label positively for B cell markers. And then the surrounding smaller lymphocytes often will label with an admixture of T cell markers. So the cells here will be CD20 positive. And then in these germinal center areas, you'll often see a meshwork of CD10 positive cells. The areas that are the neoplastic B cells are going to be CD5 negative, so not marking for a T cell marker. And that's important, especially with the diffuse pattern, if your differential was like a CLL. So CLL will often have co-expression aberrantly of T cell and B cell markers. So if you have a diffuse pattern of a follicular lymphoma, it's important to note that this is CD5 negative. And then for patients that have been treated with rituximab, it's important to note that their follicular lymphomas can lose expression for CD20. So if you have a patient with a history of a follicular lymphoma that's been treated with rituximab, it's important to note that post-treatment, those lymphomas can lose their expression of CD20. And in those cases, you might want to get a CD79A, or a PAX5. And those markers are usually still expressed in their follicular lymphomas. So if it's been treated with rituximab, again, important, CD20 expression can be lost, and you might want to get a PAX5 or a CD79A. And these lymphomas, most of them are going to be BCL6 positive. And if it's a secondary skin involvement and an underlying systemic lymphoma, those are oftentimes going to be BCL2 positive. So again, if it's a patient with an underlying systemic lymphoma, in those cases, these follicles here will show BCL2 expression. So important to note that distinction. And then sometimes for boards also, they might mention an alternative name for CD20. CD20 is also known as L26, and that's an older name. But just know that L26 is another name for CD20. All right, here we have an example, and you can see this is from the scalp, which again is one of the common locations for follicular lymphoma. And we can tell that we've got some hair follicles here, and then these collections of neoplastic follicles. And you can see the germinal centers are of varying size. So we have some large germinal centers and smaller germinal centers. And as we go in a little closer, you can see that we have some centrocytes and centroblasts. So the centrocytes have these smaller, darker nuclei that have sort of a cleaved nucleus. So you can see there's a little line through them, kind of like a little coffee bean. And then in contrast, the centroblasts have a larger, more open chromatin structure, and then this prominent nucleolus. So centrocyte, smaller, more compact, centroblast, larger and more open nucleus with this kind of paler looking chromatin structure. And there's often a Grenz zone, so there's some sparing without involvement of the overlying epidermis. And in contrast to a marginal zone lymphoma, we don't see immunoblasts. There are not many tingible body macrophages, and these tend to be, again, BCL2 positive if there is secondary cutaneous involvement versus being mostly negative if it's a primary cutaneous. So again, that BCL2 is important here. And I also just wanted to mention for these cases that Ki67 within the neoplastic follicles is often scattered throughout the entire infiltrate or is only moderately elevated in these germinal centers at about a rate of 50%, whereas in a reactive lymphoid follicle, in these proliferative germinal centers, it's often going to be much higher. The Ki67 or MIB1 is the other name for Ki67 is going to be much higher in a reactive lymphoid follicle. So important to know for that. And then in your differential, you might also think of a cutaneous lymphoid hyperplasia. And those tend to be more top heavy. So here we see that this infiltrate is more bottom heavy. The infiltrate tends to be more polymorphic with more lymphocytes, more plasma cells, macrophages, neutrophils. Germinal centers tend to have a thicker mantle zone, more tingible body macrophages, and tend to spare the adnexal structures, whereas here we see some involvement of the adnexal structures, so kind of involving the follicles. So this is a bit dense and a bit deep, and not many eosinophils, not many tingible body macrophages. And then the depth and density here favor a follicular lymphoma for this one. All right, so the next case I'll be sharing is the family of the B-cell lymphomas is a marginal zone lymphoma, and the older name for this is an immunocytoma. And this is the next most common of the lymphomas, also a B-cell lymphoma, also a lymphoma with an excellent prognosis. And these lymphomas are indolent lymphomas. They derive from post-germinal center B-cell lymphocytes with plasmacytic differentiation, and these tend to show clonality either of kappa or lambda light chain restriction, so that's important in the diagnosis. And these are restricted to the skin at the time of diagnosis. These have an excellent 5-year survival rate of greater than 90%. They show no epidermal involvement. So here you can see this really nice Grenz zone, and then a diffuse dermal infiltrate of blue cells. And if we go up a little higher here, you can see that there is an admixture of small and kind of larger lymphocytes. So we see many small, kind of round lymphocytes, and then an admixture of some of these cleaved cells, similar to what we were seeing in the center of those germinal centers, but they're not as nicely compact and organized as they were into follicles in our previous example of the follicular lymphoma. They're a bit more diffuse, but the cytology is very reminiscent to what we saw before. So we're seeing some of these immunoblastic cells with the, or centroblastic cells with the open chromatin and these prominent nucleoli. And then again, some of these smaller cleaved cells with the darker nuclei and that central kind of linear structure here. So we're seeing centroblasts and then also centrocytes. And then an admixture of other lymphocytes here. So small lymphocytes and lymphoplasmacytoid cells. A few plasma cells are seen at the periphery here. So if we cruise around the edges, we start seeing a few admixed plasma cells at the periphery. So here's a plasma cell, an eosinophil, and there may be reactive germinal centers. And then we commonly find tingible body macrophages, and there are often associated T lymphocytes. So at the periphery here, we see some small T lymphocytes associated with the inflammatory cell infiltrate. So we have kind of an admixture, kind of a mishmash of all sorts of different lymphocytes here. Light chain restriction is important. We may see Dutra bodies. These are CD20 positive, CD79A positive, BCL6 negative, CD5 negative. And the differential diagnosis here is pseudolymphoma. Often what you'll see here is this kind of vertical growth pattern with streaming down through the dermis and extending to the subcutis with that typical Grenz zone. At low power, this can look maybe more inflammatory. You might even think of like lupus or a pseudolymphoma. But an inflammatory process might be in your differential diagnosis. And cytologically, these don't look terribly atypical. So the lymphocytes, while slightly enlarged and maybe centroblastic or immunoblastic, don't have high-grade cytologic atypia. There's a nice admixture of different lymphocytic populations in here, but overall they look pretty cytologically bland. And that's typical for what we see with a marginal zone lymphoma. And then just to show you our light chain restriction, I'm not sure which is which here because the labels are pretty well covered up here, but I think this is kappa. And you can see here that the plasma cells, which do tend to be at the periphery of these nodules of lymphocytic inflammation here, the plasma cell cytoplasm is lighting up pretty nicely here with kappa. And then if we compare that relative to the lambda, you can see that there's much less lambda staining. So we have a pretty nice kappa restriction here, which is supportive of a marginal zone lymphoma. So that's, again, the next most common of our B cells. All right, the next of our lymphomas is diffuse large B-cell lymphoma leg type. So this is a biopsy from the lower leg, and you can see in this case, in most cases, there's more of a diffuse dermal infiltrate. So this one is involving kind of the deeper dermis and the subcutis. But what I want to focus on first here is the cytology of this infiltrate. So if we compare this to what we saw previously and our normal lymphocytes kind of at the periphery, what I want you to notice first here is that there's a higher grade degree of cytologic atypia here. So there's more smudging of the nuclear chromatin, more mitotic figures, kind of more crowding of the lymphocytes. And overall, this is just a higher grade lymphoma. So an increased nuclear cytoplasmic ratio, and that corresponds really clinically with the higher grade behavior of this lymphoma clinically. So these are more aggressive lymphomas with a much worse 5-year survival. So important to recognize that corresponding with this high-grade cytologic atypia is a worse clinical behavior. These patients do not do well. There's about a 50% 5-year survival rate. With these lymphomas, they tend to occur in more elderly individuals, more in women, more on the lower leg, but they can occur in other areas. So they do occur in men and they do occur in sites outside of the lower extremity. These may be primary or secondary, and they're composed predominantly of these large lymphocytes with a prominent nuclear membrane, high-grade cytologic atypia. It's a specific category of lymphoma. They tend to be bottom heavy, again, composed of these large atypical lymphocytes with a vesicular nucleus, lots of mitotic figures. These are often treated with radiotherapy. They don't tend to respond well to chemotherapy. Immunophenotypically, these are CD20 positive, and very important to remember for boards, these are MUM1 positive, MUM1, and FOXP1 positive. Also to mention, PAX5 is often positive with these cases, and another name for MUM1 is IRF4. About 10% of these cases can be negative for BCL2 or MUM1, so just important to note. And these cases may also show c-MYC positivity. And then this area, you can also see crush artifacts. So these atypical cells also tend to be more fragile and do tend to show increased crush artifacts. So you can also see that in other high-grade, kind of more aggressive tumors, including Merkel cell. And this is another example of a DLBCL leg type. This is more typical for what we would see. So kind of this diffuse sheet-like dermal proliferation of these atypical lymphocytes. Typically, you're not going to see epidermotropism. So you notice that there are no atypical lymphocytes in the epidermis here, kind of a narrow Grenz zone without any epidermal involvement. But again, this sheet-like diffuse dermal infiltrate of these highly atypical pleomorphic lymphocytes with a high nuclear to cytoplasmic ratio, frequent crush artifacts, lots of mitotic figures. And really immunohistochemistry is going to be very helpful here. So this would be one of those cases where, kind of going back to the beginning of the lecture, it's very difficult to tell whether this is a B or T cell lymphoma. So this would be one where you would want to start off with a CD3 and a CD20 and perhaps some clinical history, site on the body. Your age, location, and history are important. But this, I would start with a 3 and a 20 to see, is this B cell, is this T cell, quite a few unstained, and then kind of go from there to further whittle down your workup. But this could be, an ALCL with a lot of crush, a T cell lymphoma, NOS, depending on what your markers show. But this was a MUM1 positive T cell lymphoma that was most consistent with a DLBCL leg type. The next case is courtesy of Path Presenter. We actually don't have a case of this in our study set, and this is something that you might more commonly see in the inpatient setting, or if you're working as part of a hospital setting or inpatient consult service with oncology. This is actually a case that you can see is more of a superficial and deep vasculocentric infiltrate. And what you'll notice is that it seems to be centered around the adnexa. And as we go up higher, you can see that these clusters of cells are actually within the vessels. So when we go up to higher power, you can see that there are these large kind of hyperchromatic cells that are within the vascular lumina. So what we see are these superficial and deep subcutaneous vessels that are filled with unusually large B cells. And you wouldn't be able to know just by looking that these are B cells. So again, you would need your B and T cell markers, but these are CD20 positive and CD79A positive, usually also PAX5 positive B cells. And this is an unusual intravascular large B cell lymphoma that tends to spread with intravascular hematogenous spread. And these present as bruise-like lesions clinically. These are usually also positive for BCL2. And rarely may also express other markers, but this is a pretty unusual scenario that you might not see very often. So an example of an intravascular B cell lymphoma. All right, next we're going to be moving out of B cell lymphomas and into the realm of T cell lymphomas. And the most common T cell lymphoma that we're probably all going to see is cutaneous T cell lymphoma, or Cesare syndrome. And this is one that oftentimes requires multiple biopsies for a diagnosis, especially in patients early on in their disease course. So I often counsel patients that multiple biopsies may be required for diagnosis, especially if they've been treating with steroid. If it's a more classic presentation, sometimes we can get it on the first try, but it can be helpful to take several shave biopsies, especially if it's patch stage, because the areas of epidermotropism can be subtle. And in this particular case, this was a patient who had several biopsies that were submitted, and only one of them really showed nice diagnostic features. So sometimes I'll tell people it might take, biopsies every 6 months or once a year for a couple of years until we get a diagnosis. But the nice thing is, if your differential diagnosis is a spongiotic dermatitis, that the treatment is oftentimes the same. So you're going to treat them with topical steroids or phototherapy, and oftentimes your treatment would be the same as it would be, say, for an eczematous dermatitis. Now, obviously, if their clinical course changes, if they're developing tumors or nodules, or they're progressing in a way that's different from T1A stage or patch stage disease, you would want to manage them differently or biopsy sooner. But if they have patch stage disease and it's kind of a typical MF in that double covered distribution, but your biopsy is not diagnostic, then you just want to continue to follow them and treat them as if they're MF, but it's just not quite there yet with the diagnosis. Oftentimes H&E is the gold standard for diagnosis. And here we can see kind of some of those typical features where we have a normal stratum corneum, so we don't have much in the way of spongiosis. Now, if you look very closely, you can see that there are some spaces between the keratinocytes here. So technically there is a tad of spongiosis, but for the most part, we have a pretty dry scale. And what really catches your eye from low power is how dark these lymphocytes are. And the fact that the lymphocytes are kind of peppering or tagging along at the dermal epidermal junction. So from very low power, this might just look like a spongiotic dermatitis or a perivascular dermatitis. But what we see is the lymphocytes peppering at the DEJ. And they're lining up here. And if we go in a little closer, you can see that a few of the lymphocytes have a darker nucleus or a little bit of nuclear hyperchromasia. We start to see a few little collections of these hyperchromatic lymphocytes in the epidermis. And when we see dark lymphocytes in the epidermis, largely in the absence of spongiosis, that is what we term epidermotropism. When there's more spongiosis, or when we see Langerhans exocytosis associated with those lymphocytes in the epidermis, then we call it exocytosis. So dark lymphocytes with no spongiosis, epidermotropism. Lymphocytes with spongiosis, exocytosis. So those are two of the different terms that we'll use. We also start to see some perivascular lymphocytes here. And what you can see is that more of the lymphocytes are on the top of the vessel versus on the bottom. And that's another sometimes helpful clue that you can use in the diagnosis of MF, is what we call the bare underbelly sign. So more of the lymphocytes that are coming out of these vessels are tracking up toward the epidermis, as opposed to just kind of going buckshot around the vessel. So instead of kind of going all about the vessel and going all around into the dermis and going every which way out of the vessel, more of them are tracking up into the epidermis. And that's one of the signs that we can use as well for mycosis fungoides. But here you can start to see some of that peppering and the alignment of the lymphocytes at the DEJ and some of this nuclear hyperchromasia. So a few of these cerebriform nuclei of the individual lymphocytes. Now, when we mark up our typical MF, if you get a scenario like this on the boards, they might give you this picture. And the most common thing that you're going to see with this pattern would be MF. Now, an epidermotropic CD8 positive T cell lymphoma can also give you this sort of picture. And that's important because that can be more aggressive clinically, but that's a less common variant. You can also see that in younger individuals as kind of a hypopigmented variant of MF. But the most common variant that you're going to see is a CD4 positive T cell lymphoma with an increased expression of CD4 to CD8 positive T cells. So it'll be CD3 positive, CD4 positive in a ratio usually of greater than 10:1, with loss of normal T cell markers, including CD2, CD5, and CD7. Now, it's important to note that that loss of expression of CD5 and then CD7 most commonly, but also CD2 and CD5 can be seen in other disorders. So if you have chronic eczema or you have a chronic spongiotic dermatitis, you can also get some of those loss of markers. And just because you lose CD5 and CD7, or you have a positive clone of T cells, does not mean that you have CTCL. So you can have a positive gene rearrangement in other disorders that are not T cell lymphoma. So your clinical together with your histology is very important. And that's why I like to really lean on the H&E and not so much on the immunophenotype. Number one, it's really expensive to order all of those markers. And number two, if you lean too much on the immunos, you can get yourself in some trouble with other disorders that can have aberrancies of those immune markers. But this is a classic kind of prototypical patch stage MF. And there are some other variants that you need to be aware of. But here's kind of like your prototypical patch stage MF. Now, it's important to know when looking at your markers that CD4 will also label Langerhans cells within the epidermis. So you need to do a little mental subtraction to kind of take those cells out. But here I wanted to show you another nice example of Pautrier's microabscesses. And here you can see these collections of atypical lymphocytes forming little nodular aggregates within the epidermis. So this is a nice example of Pautrier's microabscesses. And then here in the dermis, you can also start to see these collections of lymphocytes, atypical lymphocytes in the dermis. So here we've gone beyond patch stage and we're starting to get into more of a plaque of mycosis fungoides. And as you get more advanced, you can tend to lose some of the epidermotropic cells. Also important to note that Cesare syndrome can have very subtle histologic features. So you always want to make sure that you share with your dermatopathologist what your clinical suspicion is, especially if you're looking for Cesare syndrome or something that can be much more subtle like that. But here we have a nice example of the Pautrier's microabscess and then these atypical cells in the dermis here. Now you can distinguish these from Langerhans cells. I think maybe you might be confused, or I could see how you could confuse maybe just these individual areas with a Langerhans cell microabscess. But if you look at the adjacent epidermis, there's really very little in the way of spongiosis here. And you start to see the alignment of these atypical lymphocytes with a prominent halo at the dermal-epidermal junction. And then these nodular aggregates of these very atypical lymphocytes in the dermis are not something that you would see in a spongiotic process. So this is a T-cell lymphoma. These are atypical lymphocytes. These are not Langerhans cell collections in what you might see in like a contact dermatitis. So those are all ways that you could differentiate this, say, from a spongiotic process. And again, important to note that background antigen presenting cells will label with CD4. Those are normal residents of the epidermis. And they do have more of a spindled architecture. You can see those really nicely on your immunostains, whereas the atypical lymphocytes, if you correlate that with your H&E, you're going to see them in the same place that you see them on the H&E. So you're going to see them lining up here. You're going to see that they're larger cells that are more of the circular shape, and they're not going to have those dendritic processes. We do not have an example of this in our study set. So this is another example courtesy of Path Presenter, and this is an example of tumor stage MF. And here you can see that there's a dense dermal infiltrate of atypical lymphocytes. Again, you can see they have this haloed appearance, and they're really smashed up against the dermal epidermal junction here with some epidermotropism. So some of the cells are at the DEJ and then also kind of diffusely throughout the dermis and extending along adnexal structures deeper into the dermis here. And histologically, they look very similar to what we saw before. And these collections often have a cerebriform cytologic appearance. You may see large cell transformation. Epidermotropism may be lost, and there is no Grenz zone. Immunophenotypically, these show the typical MF phenotype with CD3 positivity, CD4 greater than CD8, and you may see large cell transformation. That is defined as cells that are 4 times larger than a lymphocyte in greater than 25% of the population of cells. Those cells for large cell transformation do not have to be CD30 positive, but it's important to note for MF now whether the cells are CD30 positive because they are using that in treatment. But it's not required that the large cells be CD30 positive in order for it to be transformed. It just needs to be greater than 25% of the cells that are large for it to be considered large cell transformation. All right, now I'd like to show you an example of Cesare syndrome. And this is why history is so important here. So I just wanted to share this an example. We actually don't have an example in our study set. So again, this is courtesy of Path Presenter, but this is one of the challenges of Cesare syndrome. So often epidermotropism is lost, and I think you would be challenged to make a diagnosis of Cesare syndrome without the history here. So just looking at first blush, there's perhaps a bit of epidermal spongiosis here with a little focal hyperorthokeratosis, and then a relatively dense superficial to mid-dermal perivascular, almost nodular lymphocytic inflammatory infiltrate, maybe slightly interstitial. So it looks a bit too dense, I think would be your only clue for a normal spongiotic dermatitis. So the density of the inflammatory infiltrate is a bit much for what we would see with a normal eczematous process. So it's a bit too dense and a bit too much for what we would normally see. And that might be the only clue here that something is a little bit off or something's not quite right. So perivascular infiltrate with atypical lymphocytes where epidermotropism is really rarely seen. And looking a little bit closer, the inflammatory infiltrate itself is relatively monotonous. So from field to field, the lymphocytes look fairly similar. So morphologically, they look slightly hyperchromatic. They're a little dark, but without having clinical history here, I think you might be a little bit lost as far as what to do with this. So this might be one where I would get at least a CD3 and a CD20 to see how this marked up just because of the density of the infiltrate and call to get a little bit more history. But without having any history, I would be worried maybe more about a lymphoma. But this was actually a patient with a history of Cesare. And I think if we go over and look in this other field here, there's maybe what I could hallucinate is apotriase and maybe a couple of atypical lymphocytes in the epidermis, maybe one here at the dermal-epidermal junction. So there are some very subtle clues that point you in the direction that something's just a little bit off and to dig a little bit deeper. But again, without having some clinical history, I think this is a very challenging diagnosis to make. And often Cesare, at least clinically when I was training, is something that we did more with blood work and flow And sometimes if they did have some skin findings, we would take a biopsy, but usually those findings are very subtle, and really take kind of an experienced dermatopathologist knowing what to look for and knowing that they need to look for it in order to find. So again, if you're looking for Cesare syndrome, really important to let your derm path know that clinical history and know what they're looking for to have high index of suspicion. And again, taking a few samples from a few different areas that are untreated is very helpful. All right, so the next broad zone of categories that we'll be covering continues on in the T-cell lymphomas, and these are the CD30 positive lymphoproliferative disorders. And after cutaneous T-cell lymphoma, this is probably the next large category of T-cell lymphoproliferative disorders that you will encounter. And again, this encompasses a group of both indolent and more aggressive conditions. So we can see both more benign conditions with less aggressive behavior like primary cutaneous ALCL, or conditions that are more aggressive like secondary systemic involvement of ALCL. And those can show identical histology, so your clinical information is really important there. We also see LYP in its various forms. So lymphomatoid papulosis is another CD30 positive lymphoproliferative disorder. And there are several different variants that can show different morphologies that mimic other conditions, but really the type C is kind of the classic. And then CD30 positive lymphoproliferative disorders in immunosuppressed patients or transformed MF are another group of more aggressive CD30 positive lymphoproliferative disorders. So my apologies, I'm just going to go through. This is a case of wedge-shaped infiltrate from low power, and we can see quite a bit of dermal hemorrhage. And you can see that this is composed of some lymphocytes. And from scanning magnification, you can see that there are a few larger cells. So we start to see these bigger cells with an abundant open chromatin and a prominent nucleolus. And again, some larger cells. So compared to the normal lymphocytes that are out at the periphery, these are much more larger and atypical appearing. There's, again, some associated hemorrhage, but this is kind of a dense and atypical looking lymphoid infiltrate. So to further categorize this inflammatory infiltrate, we did just a basic workup, and given that there were some larger looking lymphocytes in here, performed a few additional markers. And clinically, this was described as hemorrhagic papules, and they were worried about an infectious process versus a vasculitis because there were several hemorrhagic kind of papulonodules on the arms and legs. So here we have a CD3 stain, and you can see that there are T lymphocytes. And then here we have a CD20 stain with many fewer B lymphocytes. And lastly, a CD30 stain. And you can see that many of those larger lymphocytes that we looked at earlier are labeling with CD30. And this is an example of the classic or wedge type of lymphomatoid papulosis. Now, your differential here may include ALCL, but in the setting of self-regressing papulonodules in multiple different stages of evolution with ulceration, that clinical history really fits well with lymphomatoid papulosis. However, if we didn't have clinical information, I would just sign this out as a CD30 positive lymphoproliferative disorder, because without that clinical information, this identical histology could be seen in ALCL. It could also be seen in transformed MF. And in that case, you would typically see maybe some epidermotropism. And here you actually do see some lymphocytes in the epidermis. So you can see that in MF, and then maybe in another CD30 positive lymphoproliferative disorder. So clinical information is very important. But in the setting of multiple lesions in different stages, and a patient who's otherwise well with no history of lymphoma and no underlying systemic symptoms, this is consistent with LYP. But these patients sometimes can have other underlying lymphomas, may go on to develop lymphomas. So again, close clinical follow-up is very important whenever a patient is diagnosed with LYP. So our classic version is going to be the wedge-shaped polymorphous infiltrate with these scattered large lumps of coal or atypical lymphocytes. And then there are several other LYP variants. This is another example of a case of lymphomatoid papulosis. And here you can get maybe a vague sense that this is somewhat wedge shaped. So kind of a coming to an apex here in the mid dermis of a lymphoid infiltrate with an overlying epidermal ulceration. And the stain here is a bit different. So you can see that from low power, this looks a little bit less blue. But as we zoom in, you start to get a sense that there is a somewhat monotonous inflammatory cell infiltrate. And you can get a sense again that there is a larger nuclear to cytoplasmic ratio with an admixture of some neutrophils. Occasionally you can see some eosinophils. So we see this polymorphous infiltrate, and it's not diffuse sheets of atypical lymphocytes. So this doesn't look like the DLBCL that we saw before, where every single cell was atypical, that diffuse large B-cell lymphoma leg type. Here we're just seeing scattered lumps of coal, as they're referred to. So scattered hyperchromatic atypical cells in this background of a more polymorphous lymphoid infiltrate. So scattered larger cells in a background of a mixture of somewhat enlarged, slightly atypical lymphocytes, but grading the cytologic atypia, this doesn't look as bad as some of those more atypical lymphomas that we saw previously. The immunophenotype of these is typically CD3 and CD4 positive, to a lesser extent CD8 positive, and then as the name or the category is characteristic, often CD30 positive. So again, this is an example of the type A or more wedge-shaped LYP. And these cases are all courtesy of Path Presenter, so these other examples that I'm showing you. So thank you to the group there for sharing these cases with us. This is another example of Mycosis fungoides, and this looks very, or sorry, of LYP, and this looks very similar, sorry, my brain got ahead of me there, to Mycosis fungoides. So type B LYP may look histologically indistinguishable from Mycosis fungoides. So here you can see that there is an epidermotropic infiltrate of atypical lymphocytes that are hyperchromatic with perinuclear halos, and without any clinical history, this band-like infiltrate is really kind of indistinguishable from MF. So clinical history here, important, and then knowing that these cases are CD30 positive is helpful. Continuing in our types of LYP, type D lymphomatoid papulosis is going to resemble CD8 positive epidermotropic T-cell lymphoma, and again, the pathology there is going to resemble Mycosis fungoides, but in lieu of being CD4 positive, those cases are more typically CD8 positive and then also CD30 positive. Type E LYP is an interesting variant. It's the angioinvasive and angiodestructive variant, and these can mimic a natural killer T-cell lymphoma. And sorry, I skipped over a part, or type C. Type C is more of a diffuse dermal infiltrate, a sheet-like infiltrate of those atypical lymphocytes that resembles cutaneous anaplastic large cell lymphoma. And we don't have an example of that to share. But this is an example of type E lymphomatoid papulosis. And this is a case, again, courtesy of Path Presenter, where there's an ulcerated epidermis with necrosis. And as we zoom in closer here, you can see that these atypical lymphocytes are really vasculocentric. So they're within the vessel lumina, and they're demonstrating areas of vessel necrosis. So all of these atypical lymphocytes are really homing to the perivascular space and resulting in vascular destruction and vascular thrombosis. So here you can see an area where those atypical hyperchromatic lymphocytes have really destroyed the vessel wall and led to vascular thrombosis here, with the resultant overlying epidermal necrosis. All right, the next entity that we'll be discussing in the CD30 positive lymphoproliferative disorders is cutaneous ALCL. And this is in the differential diagnosis of our type C LYP. And there are two variants that it's important to be aware of because they have different prognoses. So primary cutaneous ALCL is typically seen in older patients and may show spontaneous regression and typically has an excellent prognosis, whereas nodal lymphoma with secondary involvement of the skin tends to be seen in younger patients and may have a worse prognosis. Both of these are usually CD30 positive. The other name for that is KI1. And in cases that are CD30 negative, those may have a worse prognosis. Also important to note that nodal lymphomas or secondary involvement with the skin tends to be ALK1 positive, although that is not 100% specific. So you may see rare cases of ALK1 positive primary cutaneous lymphomas, but that's the exception. So in general, ALK1 positive lymphoma, if it's ALCL, tends to be a nodal lymphoma, and those tend to be the ones that have a poorer prognosis and tend to occur in younger patients, whereas the primary cutaneous ALCLs do tend to occur in older patients and have a better prognosis and tend to be ALK1 negative. So this is an example of cutaneous ALCL, and they can be more diffuse than this. This is a little bit more of a nodular variant, but here you can see that there is a superficial and deep nodular to diffuse infiltrate of lymphocytes in the dermis. And as we go up and look at these a little more closely, they resemble the LYP cells that we saw earlier. So to me, these look more like the cells that we were seeing in the LYP or the transformed MF versus the cells that we were seeing in the DLBCL that were more smudgy and more high grade, had more high grade atypia. So these, I think we can still tell are lymphocytes, and they look a little bit more like those lumps of coal. But again, here, immunophenotyping is going to be helpful because we're going to need to determine with certainty that these are B versus T cells. So again, a CD3 and a CD20 would probably be your first step. And this one, I would probably be suspicious of an ALCL, so I would probably get a CD30 in the beginning as well, along with some unstained. These can variably have loss of some markers, and then usually we'll also check in ALK1 to see if it's positive or negative to try to determine whether this is a primary or secondary lymphoma. But again, clinical correlation here is often necessary to distinguish those two. And in this case, it's important to distinguish that more than 75% of the cells should be CD30 positive. And then continuing on in our differential of CD30 positive lymphoproliferative disorders is large cell transformation of Mycosis fungoides. In this case, we can see, similar to in our previous examples, that there are Potteries microabscesses. So we have collections of atypical epidermotropic lymphocytes. There are a few scattered single lymphocytes at the junction, but for the most part, they're collections of these aggregates within the epidermis, and then also kind of a band-like collection of enlarged, somewhat hyperchromatic lymphocytes throughout the dermis. And large cell transformation, again, the prerequisite for that is that more than 25% of the lymphocytes are greater than 4 times the normal size of a lymphocyte. They don't necessarily have to be CD30 positive, but more than 4 times, or more than 25% of the cells need to be greater than 4 times the cell of a normal lymphocyte in order for it to qualify as large cell transformation. The next entity is primary cutaneous CD4 positive small to medium T cell lymphoproliferative disorder. And this was previously classified as a lymphoma, but now is considered a lymphoproliferative disorder, more along the lines of a cutaneous lymphoid hyperplasia. So this is believed to be a reactive process. And histologically, we see a nodular collection of diffuse small to medium-sized lymphocytes. Scattered large cells may be present. There may be foci of epidermotropism or adnexotropism, and there are numerous reactive B positive cells. You may see CD8 positive reactive lymphocytes and sometimes histiocytes also present. The classic immunophenotype of this disorder is CD3 positive and CD4 positive with or without CD30 positive cells. Usually these are CD56 negative. And you may see these rosettes. So you may see these clusters of cells arranged in a rosette fashion. T cell clonality with positive gene cell rearrangement is often seen. And clinically, these are usually solitary erythematous to violaceous tumors or nodules on the face or chest and upper trunk. And again, these were previously categorized as a lymphoma, but because of their indolent clinical behavior, they are now reclassified as a lymphoproliferative disorder. All right, the next entity that we'll consider is a Peniculitic lymphoma. And I think here you can see that the majority of the inflammatory infiltrate is centered throughout the peniculus in both the lobular and somewhat septal configuration. So you can see that there's some blue cell infiltrate throughout the septum and then throughout the lobule of the peniculus. And typically when we go in on higher power, the characteristic feature that you see here is rimming of the adipocyte. So what they describe as the inflammatory cell infiltrate surrounding the fat lobule here. And you may or may not see involvement of the overlying dermis and or dermoepidermal junction. And some authorities consider that this may be a variant or kind of in a progression with subcutaneous lupus or lupus peniculitis. Now, in contrast with lupus peniculitis, with subcutaneous peniculitic T-cell lymphoma, you should not see hyaline necrosis of the fat. You typically will not see lymphoid follicles as you may see in lupus, and you shouldn't really see interface dermatitis at the overlying dermoepidermal junction or basement membrane smudging, although here, you might say that there's a little bit of interface here. And I think that does present some evidence that this may be a progression of perhaps lupus progressing to lymphoproliferative disorder or to a frank peniculitis. But typically what we will see in this entity is immunophagocytotic or excuse me, if you could just edit that out, Ethan, sorry. What you typically see here are these beanbag cells. So you will see macrophages that are stuffed with debris of many different cells. And you see remnants of polymorphic karyorectic debris and histiocytes with granulomatous features. Plasma cells may be present, and these can have an increased Ki67 proliferation index of the lymphocytes surrounding these individual fat lobules. And that's something that is supposedly going to help characterize a subcutaneous peniculitic T-cell lymphoma from subcutaneous lupus. So let's say you have a case that doesn't have much in the way of hyaline necrosis. If you were to check a Ki67 and you see increased Ki67 activity around these fat lobules, that would point more in the direction of a subcutaneous peniculitic T-cell lymphoma versus this being lupus. These are typically CD3 positive, CD8 positive, and you may see CD123 positivity, which you also tend to see clusters of CD123 positive cells in connective tissue disease. So again, that supports some evidence or some possible etiology corresponding to underlying connective tissue disease. These also have a beta F1 phenotype or an alpha beta T-cell phenotype, in contrast with gamma delta T-cell lymphoma, which is another subcutaneous T-cell lymphoma that tends to have a very aggressive clinical course. So we're not going to talk about that today, but important to note that alpha beta T-cell lymphoma tends to be the subcutaneous peniculitic T-cell lymphoma, which is more of a low-grade lymphoma, in contrast to gamma delta T-cell lymphoma, which is another peniculitic T-cell lymphoma that tends to be much more aggressive clinically. Also in the histologic differential diagnosis, you may consider cytophasic histiocytic peniculitis, and that tends to be more of a lobular peniculitis with neutrophils, macrophages, and plasma cell. And you see cytophagocytosis with macrophages engulfing erythrocytes, lymphocytes, and karyorectic debris there as well with the beanbag cells. But the atypical lymphoid infiltrate may be present in association with an underlying lymphoproliferative disorder. And again, that's a lobular peniculitis as opposed to a mixed lobular and septal peniculitis. And then you might also consider an extranodal NK T-cell lymphoma, much more high-grade atypia and tends to have more necrosis. And then lastly, I'd just like to touch on leukemia cutis. And 90% of leukemias are B-cell, and T-cell leukemias have an increased incidence of cutaneous involvement. And the histology is going to reflect the underlying type of tumor. The density of the infiltrate and the histologic picture are variable. So as you can imagine, we've seen several different morphologies of lymphoma today, and what you see in the skin will mimic what you see in the underlying systemic lymphoma. One of the most common lymphomas that we'll see, and sometimes as an incidental finding, is CLL. And chronic lymphocytic leukemia is one of the more common leukemias that we'll see, especially in older individuals. And we can see that as an incidental finding in excisions of squamous cell carcinomas or other tumors. And it tends to be a small cell cutaneous lymphoma. And we see the same sort of pattern on path. So what you tend to see are this nodular, monotonous blue cell infiltrates. You can see from field to fields, there's just an increased density of these very small blue cells. And the typical immunophenotype here is an aberrant expression of CD20, which we usually see with B cells, with CD5, which is normally a T cell marker. So that aberrant expression is something that we may see with cutaneous B cell CLL. Now, the pattern that we see over here at the edge is something that we might see perhaps in a myelogenous leukemia with this Indian filing, but the cytology is different. So we would see more of like an immunoblastic phenotype. So let me see if I can find cells that are better representative of that. All right, so here's an example of the cytology that I was speaking of that you might see with leukemia cutis. And this was a patient with an underlying myelogenous leukemia with secondary skin involvement. And what you can see here is there's a bit of a Gren zone. So we have a little dermal epidermal separation here and a little narrow area of papillary dermis that's uninvolved, and then a diffuse dermal sheet-like infiltrate of blue cells. And in contrast to the CLL that we were just looking at, these cells are much larger with much larger open vesicular chromatin and a larger nuclear to cytoplasmic ratio. I don't really see a normal lymphocyte here for comparison, but these cells are much larger and they have more of an immunoblastic or centroblastic appearance to their nuclei. Maybe more of like a centrocyte here with kind of a cleaved nucleus, but much larger. These cells do tend to label with CD43 and also CD68. So those are good markers if you're thinking of a myelogenous leukemia to kind of start with, in addition to your CD3 and CD20 to see if it's more of a B or T cell proliferation. Other markers that we use to look for cytotoxic differentiation include myeloperoxidase, TIA, and granzyme. Those are some different markers that we can look for. But that's kind of a general overview of some of the more common leukemias and lymphomas, T cell and B cell lymphoproliferative disorders that you'll see, including low and high grade. So it's a lot to digest and a lot to keep track of, and the classifications change. But overall, those are some of the big things and more common ones that you'd see. So I would say focus more on markers, B and T cell markers, indolent versus aggressive behavior. Make sure that you know your markers for Mycosis fungoides. So know that that is going to be more commonly CD4 positive versus CD8 positive. You would tend to lose expression of CD2, 5, and 7. They may show CD30 positivity, and know that CD8 positive T cell lymphomas, the epidermotropic, can show a more aggressive clinical behavior. For your B cell lymphomas, you want to know that the MUM1 lymphoma, the leg type, shows a more aggressive behavior, as well as the gamma delta lymphoma shows a more aggressive behavior. So if you can kind of parse those out into more indolent versus more aggressive, and then kind of the markers that go with each of those. And then for your CD30 positive lymphoproliferative disorders, if you know that your type A LYP is going to be your more common one, type C LYP can look like ALCL or transformed MF, and that your primary cutaneous ALCL tends to be ALK1 negative, and your secondary systemic ALCL tends to be ALK1 positive. Those are kind of the big take-home points that I would focus on. And then one that we didn't have an example of is the Blastic Plasmacytoid dendritic cell neoplasm. I would say know the markers for that. And that is CD123 positive, CD4 positive, and CD56 positive. And a good way to remember that is 1, 2, 3, 4, 5, 6. So that one's pretty easy as far as the markers. So Blastic Plasmacytoid dendritic cell neoplasm is another that they like to have you know the markers for. So those are kind of the big highlights, and they may change in the future. And if they do, we will add some updates to this. And there are definitely, this is not an all-encompassing lecture for lymphomas. So please know that there are many other variants and nuances, and this is by all means not an exhaustive or comprehensive lymphoma lecture, but hopefully this will get you the basics that you need to know to see more of the common things that you'll encounter in your clinical practice, and hopefully for boards. So thank you for joining us, and I hope you learned something today. Thanks so much.